Hello all, and welcome to the first episode of our RadCast podcast, and thank you Dr. Curtis for agreeing to be our first interviewee. Seeing as this is the first episode, I think we should start by introducing RadCast to the listeners and explaining really what the purpose of this podcast is going to be.
So it's an idea that myself and a couple of other UK radiology trainees have had, and the aim is to discuss interesting and topical issues in radiology, but from a grassroots perspective. So have the discussions that people like us would want to have about issues that are affecting the UK radiology workforce.
Our second aim is to use this podcast as our own attempt to try and increase the profile of radiology. It's no secret that radiologists are not renowned for being good at selling the specialty and being visible, and there are lots of stereotypes about us just sitting in dark rooms and not engaging with people outside the specialty, and we want to try and change that.
There are lots of exciting developments taking place in radiology at the moment, and we want to provide a platform to share this and increase people's awareness about the field. So that's basically our mission statement, and so we'll crack on with our first interview. And today we're going to be talking to Dr. John Curtis, who's a consultant radiologist at Aintree University, Liverpool, with a special interest in thoracic imaging and trauma. He's also the Associate Head of School of Radiology for Health Education Northwest, and apart from his clinical commitments, he's actively involved in teaching and training of radiology trainees, non-radiology trainees, and he's a specialty lead for radiology for the undergraduate medical curriculum at University of Liverpool. So thanks for being here today, Dr. Curtis.
So we're going to talk about how radiology training has changed over the course of his career, the issue of the low profile of radiology as a speciality, and then his role in trauma. So over to you now, Dr. Curtis. If you wouldn't mind telling us, what was a normal week like for radiology trainee back when you were training? Was it in the 80s?
No, it wasn't that far back. But thanks for suggesting it. It was actually in 1992 when I first started in radiology. By the way, for those people listening, the room is well lit and I can see everyone. We're not in a darkened room. So I'm going to blow that stereotype out the window. But in 1992, I started as a registrar in radiology in the Mersey scheme. It wasn't called the Mersey School of Radiology then. It was just a registrar rotation, and I started at the Royal Liverpool Hospital, and my working week consisted of 5 days. On a Wednesday we were at the university in the morning, and if I remember correctly I think we were in the university on a Tuesday afternoon, and then at some point the first years just did all day on a Wednesday. But we used to split the days in the first 2 years. So the other 4 days of the week consisted mainly of watching consultants report plain films and CTs, and the rest of the time was primarily concerned with becoming good at fluoroscopy. We had one intervention session, which was usually assisting somebody. So the bread and butter of the training I received was very much plain films, watching other people do CT, which wasn't very prevalent in those days, but doing a lot of fluoroscopy. So the idea was that registrars in those days became very proficient at fluoroscopy within about 6 months, and I think most training schemes achieve that aim.
And how do you think the workload and also the work mix compares to trainees nowadays?
Okay, so trainees nowadays have got more sophisticated radiology to learn. It often uses more sophisticated equipment techniques, and so the radiology that I learnt as a first year, some of that is redundant now, and it's been surpassed by CT, MR. And what I've found now is that the trainee of the 2010s, we're in 2018 now, most trainees will do quite a bit of CT, MR. And it is at the expense of the plain film because something has got to give, and they can't do as much plain film experience as I was used to.
I mean, it is interesting you say that, because obviously as technology has developed, the requirements of us are to do a lot more cross-sectional imaging now, and certainly with fluoroscopy in a lot of hospitals that's now done mainly by radiographers, or in large part by radiographers and the junior trainees. A lot of consultants don't do fluoroscopy anymore. Do you see maybe the same thing happening to plain films?
Well, I hope not, and the simple reason why I hope it doesn't happen is that if radiologists become good at plain films, actually CT becomes a lot easier, and plain films aren't as easy as they look. And I think it's very important that radiologists don't lose the skills of something that will stay with us for a long time. The difference with fluoroscopy is that a lot of fluoroscopy is now being superseded by endoscopy, and in the case of barium enemas, it's CT colonography. So if you like, there's a good reason why you can move other special interests into fluoroscopy at the expense of radiologists, but plain films remain the bread and butter, and I do think we have to have a control over that.
So just out of interest, how many were you expected to do in a year? Say we have to do around 1,000. What were you?
Considerably more. Yeah. So because most of our reporting, so in second and third year when I started progressing through the registrar ranks, my plain film requirements crept up, and so we had to report a fair number. So if you had 2 or 3 reporting sessions a week where it was plain films, you would be expected to shift maybe 80 films. So considerably more, but then of course we didn't have quite as much CT or MR. So it was on a like-for-like basis. It works out pretty much the same in terms of workload, but of course the emphasis was different.
So certainly for trainees coming through the system now, a large proportion of the on-call work, the out-of-hours work, is CT based. How did your on-calls compare? Okay,
so our on-call was more frequent. So you guys are probably doing about 1 in 9, 1 in 10. The most luxurious on-call rota was probably about 1 in 5 when I was on call. So it was more frequent, but radiology was used less often than it is now because of the lack of availability, the perception amongst clinicians that radiology was not as accessible as it is today. And so when I was called in to do scans, they were fairly straightforward things. What's the clinical question? Can the scan answer the clinical question? Nowadays, everyone wants a radiological opinion because it forms an integral part of the algorithm. And I think there's just been a culture change in medicine that has allowed radiology to flourish. But the downside for the radiologist is that it's made the registrar in particular very busy at night, often dealing with complex scans which, if you like, answer the question to the patient's pathway. So it becomes an essential part of on-call. And as hospitals have effectively gone over to shift systems, a shift system, if you like, it shifts the goalposts of the normal working day. The normal working day has become as long as the hospital wants it to become, and I think that has made life a lot busier for you guys.
So there's a move certainly towards subspecialisation, and fellowships are becoming more and more popular. Would you consider yourself to be a general radiologist?
Very much so. I'm a general radiologist with an interest in chest and emergency radiology. But I'm actually interested in quite a few other branches of radiology as well. And I suppose if I was asked what is your specialist interest, it would be chest radiology. Now I quite like general radiology because it makes you think outside the box. Me personally, I wouldn't be fulfilled as a pure chest radiologist, so I've got to be doing other branches of radiology. But I think there is a move, or there has been a move in the last, say, 10-15 years, for radiologists to become more subspecialised, which is good for the specialty that you are striving to be an expert in, but it's less good in terms of your ability to cope with the general workload. And the on-call, in my view, is made more bearable because it's less frequent. And you're only going to get a less frequent on-call if everyone in the team is able to play a role in that on-call rota. So general radiology, therefore, is really quite important.
Yeah, very true.
Given that we have all of these quite complex imaging modalities and scans that we have to do now, medicine has got generally quite more complicated over time. Do you think it's possible to be a generalist in today's day and age, to report MR prostates and also report MR brains to a good standard?
That's two different parts of the body.
Yeah, it's general radiology.
But you can be a general radiologist and a specialist in one or two areas, and you can be quite successful at that. I think if you go beyond two specialist interests, you then start to become a general radiologist all over again. So, being a general radiologist, if you like, a good definition of a general radiologist is somebody who can hold their own on a night on call. They can do a bit of everything. And of course, nobody's an expert on everything. And even if you're on call at night and you can't solve that particular problem because it's outside of your sphere of expertise, you can make a clinical decision that it can wait until the next day for the experts to solve the problem. Or you just get an expert on the end of the phone and say, look, this is going to change management. What should we do about it? But most cases, I think, you can apply your general radiological skills and do a decent job on call.
So, and I think a similar thing maybe applies to interventional skills. So I've noticed that a lot of the more senior radiologists seem to be more competent with your routine interventional procedures, ultrasound guided biopsies and drains, and maybe some basic CT guided procedures than maybe the younger generation. And that's probably because IR now, with the move to subspecialisation, a lot of these procedures which in the past would have been done by diagnostic radiologists are being done by IR specialists. So do you think it's a good thing for diagnostic radiologists to have these practical skills, or do you think it's safer to leave it to the IR guys who are experts?
It's a very, very interesting question. When I was a trainee, I was exposed to quite a bit of intervention. First of all, in a supervisory capacity. So I was being supervised doing procedures or assisting in procedures. And then there was a gradual cutting of the cord between the consultant and the registrar, and I was then able to do procedures. And that was the training that we had to abide by when we were trainees, and that was actually quite good because quite soon you learn to be reasonably independent about intervention. As a consultant of 20 and a half years standing, I've done quite a bit of intervention, angiography, biopsies pretty much anywhere, drainages pretty much anywhere, and now even as a consultant I see that work is now going to the interventional radiologist, because the way departments are set up now is that there is an expertise which concentrates on that particular intervention. And I think it's right and proper, because if the patient gets a better outcome because you've got more expertise dealing with that particular problem, that's a good thing. The impact for the trainee, of course, is that the number of people able to show them how to do an interventional procedure becomes smaller and smaller and more specialised. And so inevitably you're more likely to then get exposed to intervention when you're on an interventional block. And so there was perhaps an opportunity to get that in a diagnostic sense as well. and that's maybe diminished, certainly in my experience in this hospital, but I expect it's probably the same elsewhere.
So thanks for that insight, Dr. Curtis. Now, perhaps one of the most fundamental issues facing radiology at the moment is the underexposure,
no pun intended,
of the specialty. For a specialty that's so integral to the functioning of any hospital, radiology has a notoriously low profile. And when there's a growing workforce crisis, this is something that really needs to be addressed. So as someone who is always out there trying to be visible and engage people about radiology, what is your view on this, and where do you think the problem stems from?
Okay, if you start at undergraduate level, I graduated from the University of Liverpool in 1987, and in 1985 I did a 2-week placement in radiology at the Royal Liverpool Hospital. Now, since those days, I think radiology has become less noticeable amongst undergraduates. For a variety of reasons. I think the undergraduate curriculum is jam-packed with lots of other advances in medicine. Medicine, surgery, obs and gynae, paediatrics usually take the lion's share of the time allocated to undergraduates. And so radiology has kind of withered on the vine a bit. And so if undergraduates are less aware of radiology and what radiology can do for their patients, it's inevitable that this may have a negative impact on stereotypes. Now, radiology still remains a very popular specialty at specialist trainee level. From the last I heard, I think it was the second most popular in terms of specialties. So people obviously do know about radiology, but my impression is that not just in Liverpool but up and down the land, undergraduate radiology needs to have more prominence. And if you like, it's not just to try and attract people into the specialty. One of the jobs of radiologists is to allow clinicians, and I include medical students in that, to use the radiology facilities as optimally as possible. So if they get exposed in the department, they're much more likely to use the radiology department properly, whatever specialty they go into. So undergraduates are important. The second one, and I think this is very important, over the last 10 years, because radiology has become busier and busier, a lot of departments, including my own, have locked down the department to try and reduce interruptions. And actually the department is a potential venue to educate clinicians about radiology. They may, as a result of that, decide to go into radiology as a specialty, but even if they don't do that, it would certainly make them appreciate the radiology department a bit more. So it's all very well locking down your department to keep people from interruptions, but we are actually here to be interrupted, and so we can have a two-way dialogue with the clinicians.
Yeah, I always think it's good when a clinician comes down to the hot reporting room or comes down to a radiologist's office and is treated as a teaching exercise, because it's almost like a little quiz or a bit of trivia. They're always interested to see how you make your diagnoses. To a lot of them it's like black magic, so it's good that they can actually come and see how you're working.
You can actually deal with a final year medical student or an F1 or an F2. They come to your room with very little knowledge about what they're requesting. And rather than sending them away feeling ignorant, you can actually enlighten them about what they don't know, so that the next time they can be more useful and they feel a bit of job satisfaction. So that, I think that's a really vital part of the radiologist, to allow clinicians to ask questions. Otherwise they'll never learn.
I think certainly looking back at my undergraduate training, I feel as though radiology was perhaps taught as an adjunct to other things. So it was never something that was projected onto you as a career or speciality in its own right. It was a case of, if you're doing a surgical placement, you might get a bit of teaching on CT abdomens, that kind of thing. But I remember a few months back there was an undergraduate careers fair, and the foundation doctors there as well, and I was on the radiology stand, and I was surprised how many people didn't know what a radiologist was, or that you were actually a qualified doctor in the first place. And these are people who are, potentially our target market for continuing training in the future.
And you were saying that you were on the stand next to the vascular surgeons, and they had lots of cool interventional radiology kit out and were showing off all the catheters and so on, and engaging all of the junior doctors. Meanwhile, us on the radiology stand next door didn't have any of that. So I think we need to be better at selling ourselves.
I completely agree. I think a lot of the direction of travel should be about perception. And if we do a good job, and as radiologists I think we all agree that we do a pretty good job, we should tell people. Otherwise they don't know what we do. Some people may not know we actually do minimally invasive procedures which might prevent a surgeon having to operate.
Very true.
And more importantly, intervention's important, don't get me wrong, but the vast amount of our work is about putting the patient's clinician in the picture about the direction of travel with the pathway. So a lot of patients now won't get discharged or won't have a management decision made without looking at the radiology report.
So, as I mentioned in your incredibly long intro, you're currently the specialty lead for radiology in the undergraduate medical curriculum. So,
yeah,
what
just been appointed.
Just been appointed. Okay.
So,
what are your aims? And
I aim to take up the post from the 1st of August, but I've been doing a little bit of work in the background, and it's about mapping the curriculum that the medical students are currently exposed to the undergraduate curriculum which the Royal College of Radiologists has produced. And in the University of Liverpool in particular, it'll be longitudinal teaching. So if I could just explain, radiologists have a big role to play in teaching anatomy. So in the first year, radiology could actually help anatomy in addition, not replacing, what goes on in the anatomy department. And then in second year, when undergraduates are understanding the pathology of disease, radiology can explain some of those pathological mechanisms by displaying x-rays, CTs, etc. The second years then go on clinical placement, 6 separate weeks throughout the whole academic year, and we've now integrated radiology into part of those 6 weeks, so that all medical students have to get some experience of radiology in the clinical environment. The 3rd, 4th and 5th years will be all about preparing the F1 doctors for what they need to know in terms of radiology, how to interpret an emergency chest x-ray, abdominal film, fractures, a better understanding of CT, so that they can understand when they request an examination, they understand what the patient has to go through. I think that's really important. So radiology, I think, has a massive role to play in undergraduate education because it complements the understanding of surgical disease, the understanding of medical disease, the understanding of diseases that affect children, and it's a massive piece of a very complicated jigsaw. And I think by introducing radiology, not only can we allow F1 and F2 doctors to use the radiology department sensibly, but actually some of those difficult concepts might be answered by the inclusion of radiology.
Yeah, I mean, just thinking about using radiology to teach anatomy, I wasn't at university that long ago, but we were still basically just using cadavers and textbooks, and it seems a no-brainer to show students a CT scan, so you can go through, scroll through the anatomy in your own time, reformat it in loads of different planes, and just get a nice 3D impression of the anatomy. I think that seems to be, I don't know why that's not already the standard.
Well, it's starting to become more of a standard in some medical schools. Certainly in Liverpool, they've taken a bit more of a radiological slant now to anatomy, so that's now incorporated into the HARC, which stands for Human Anatomy Resource Centre. So that is happening, and let's face it, the type of anatomy that most junior doctors are encountering in their clinical practice is on a PACS workstation. Yeah. So topographical anatomy is when you examine patients, you can see certain landmarks, but the nuts and bolts, the inside of the patient, is all revealed by CT and MR. So why wouldn't you spend more time studying that type of anatomy? Notwithstanding the fact that you can understand disease by appreciating the radiology and the anatomy.
Yeah.
So, just moving on to the last topic for discussion now, we'd just like to talk to you a bit about trauma/emergency radiology, as we know this is an area of interest to you. Of course, you work at Aintree, which is the major trauma centre for Merseyside, and you're also involved in the British Society of Emergency Radiology. What do you think about the status of emergency radiology in this country?
Well, it's a fledgling organisation which was formed approximately 3 years ago. Now, a lot of district general and teaching hospital radiologists are de facto emergency radiologists because they do hot reporting. They report things on an urgent basis, either during the day 9 to 5 or on call. So if you like, we've already engaged ourselves with emergency radiology, but the purpose of the British Society of Emergency Radiology is to try and grow a bit more expertise in those areas where people either find difficult or where it's such a common problem that people need to be proficient. And so it started about 3 years ago. Dr. Elizabeth Dick became the first president, and she encouraged lots of young enthusiastic radiologists to join, and we've had 3 conferences now where we've looked at emergency radiology topics. The one last year was in combination with the European Society of Emergency Radiology. So this is a really new organisation. It's quite exciting, and we're desperate really to get new recruits from registrars, because I think most of the teaching that we can offer in the conferences and around and about is going to benefit registrars, because that's the bread and butter that you do on call. So if you like, the BSER is an organisation that aligns itself most of the time to trainees rather than consultants, but of course consultants are involved in emergency radiology all the time.
So looking specifically at trauma radiology, do you think that it could become a standalone specialty in itself, or do you think that trauma radiology will still be within the remit of everybody?
Do you know what? I don't know the answer to that question. I think at the moment, because trauma centres are concentrating most of the trauma, I would imagine that if you worked in a trauma centre, you're going to do a bit more trauma than, say, somebody who doesn't work in a major trauma centre, that might be an indication to develop trauma radiology as a subspecialism. But the problem with that is that even in hospitals that don't regard themselves as a major trauma centre, trauma will still come into those hospitals, and everyone needs to know about trauma. So it's part of general radiology, but sure, it could actually be an attractive specialty. for people who just want to specialise in trauma. I don't think that's been the experience in the United States, and we tend to copy whatever goes on in the US. So I think it'll be a part specialty, because you may work in a trauma centre where there's no trauma for a whole 48 hours.
Yeah.
What else are you going to do? You know, so I think it's going to become part of your portfolio, but not the only thing.
Certainly, looking at fellowships in North America for emergency radiology, they obviously involve trauma, but then they combine cardiac work.
Yeah.
Do you think that that's something that could happen in the UK, or do you think it will remain very systems based?
I think it can. I think one of the problems with the UK, though, that might prevent that is the workforce crisis. We may not have the luxury of being able to, pigeonhole people into different specialties. We may still have to be able to do a bit of everything. In America, I've got two experiences. Firstly, in Mass General, in 1997, they had a very thriving emergency department, both from the clinical point of view and also the radiology. And the radiologists involved in emergency radiology knew a lot about everything, so they had to be pretty good at everything, really. They had the backup of lots and lots of consultants or attending physicians in each of the specialties, so that there was always somebody to ask questions of. And I don't think we have the luxury of that even in teaching hospitals in the UK. And my latest experience was in Michigan, where the emergency radiologists are effectively doing the overnight work, and that was a reasonably thriving specialty. So it was reasonably well staffed, but the on-call was done by the chest radiologists, the MSK radiologists, the GI radiologists, the neuro radiologists, up until about 11 o'clock at night, and then it was the emergency radiologist who took over. So in that particular organisation, those members of staff worked overnight, and there has to be some way of weaving that into the UK workforce if that is going to be a subspecialty, because you can't expect people to work overnight forever.
So they work exclusively overnight, or will they do a week on, week off, like A&E?
Yeah, there was some compensation for doing it, so
Right.
it was time compensation. But that really is a kind of long-lasting situation. And I think in this country, if you were going to have an emergency radiology specialty, there'd have to be some sort of shift system.
Similar to A&E physicians.
I think so, yeah. I think so.
So, if someone was interested in getting involved in trauma radiology, you say you want people to get involved in BSER. How can they do that? Do you have...
They can join tomorrow.
Right. Okay.
Or today. Yeah, they can join today. So joining is encouraged.
Yeah.
And what we're trying to do in the organisation is to make it more affordable for registrars to go on these courses. Because at the moment, study leave budgets are being slashed all over the country, for not just for registrars but for consultants. So it's going to be the registrars who suffer most, not being able to get to these conferences. And I'd like to get to a situation where organisations such as BSER can generate enough money to make it really affordable, and that's going to enhance the education of trainees where they may not get bespoke emergency radiology education in their training schemes.
But do you have any advice on like fellowships or good places to go to get top class exposure to?
When you're a fellow, you effectively work pretty hard,
Right.
and working hard is part service, part training. So when you deliver a service, some of that work that you put in is also part of your training, because you get feedback every day on the stuff that you do, and that's part of your training. So if you wanted to be a fellow in any specialty, not just emergency radiology, you want to go somewhere where the consultants or the attending physicians are experts in their field. You want to go to a busy place so that you get as much experience in that 12-month spell as you can. And the thing about North America is that they have fantastic teaching programs. Unfortunately, they start at 7:30 in the morning. But that being said, the quality of teaching is fantastic.
Right, okay.
And the fellows at the end of their stint, 12-month stint, come out being really confident about dealing with pretty much anything you get through it.
Do you think that fellowships are going to become necessary for consultant jobs?
I don't know. At the moment, certainly a fellowship might fill in some of the gaps that you feel that you've still got at the end of 5 years. Now, I did a fellowship.
Where did you go?
I went to Mass General in Boston, and I thought that was fantastic. There may be pressure put on trainees now to get a consultant's post, and from an employer's point of view, that is to try and meet the demand for consultants to deliver service. But on the individual front, going on a fellowship is a really good thing, because you see a different country, you see a different way of working, you bring skills back that you could never have acquired in the UK. The other good thing about a fellowship, in my view, is that you go to North America or you go to another country and you actually look back retrospectively and you say, actually, the training in the UK is pretty good. So we are on a par with North America, I think, certainly in terms of ability. We may not have the resources to match compared to the US, but we have no loss of ability or enthusiasm.
That's reassuring.
So that's a really good.
That's very reassuring.
Really good thing.
Right, so I think that's us done for today. Thank you, Dr. Curtis, for being the first guest on this podcast. We've really enjoyed listening to your insight, and we hope our listeners have too. And I hope you haven't found it too much of a chore to partake.
It's been very good.
Thank
you. I hope this goes on from strength to strength. So,
yeah, well, hopefully. So we will all be back soon, hopefully, with another guest to speak to in the hot seat.
No pun intended.
And to discuss some other issues in the world of radiology that we feel are relevant to all of us. So thanks again.
Thanks again.
My pleasure.